So I was not able finally to open up the stent to the nominal diameter. So this was the final result. The idea to use a drug-eluting balloon in addition was at least to cover the stent part with a drug to avoid any additional ingrowth of tissue as a result of healing process of the stent, to keep at least this result. So we are not yet completely finished here with the case because there's another interesting aspect following. So yeah, let's just continue, please. We have 5 minutes left. Let's check the result now.
So you treated with a DEB?
A DEB, yeah, in addition.
A drug-eluting balloon, sorry for that abbreviation. Yeah. Drug-eluting balloon?
Because in our institution we have excellent results with the treatment of instant renal artery stenosis with drug-eluting balloon.
Below this treated branch, and I'm pretty sure that this second artery is occluded.
So we see here
Thomas?
that it's kind of shadow.
It's Thomas at the back. Can we stop? We have one idea here in the audience.
Yeah.
Yeah, just one comment. In retrospect, did you think that if you have used cutting balloon before stenting, this would facilitate the stenting process? This number one. Number two, did you think of putting another stent so you can get use of the radial force with the second stent just to overcome this irresistible twist?
Okay. Well, regarding your first question, cutting balloon would have been my choice, and it's a good remark. We will come back to this aspect during this case. And number two, putting in a second stent doesn't make sense. For that purpose, you would need to see that your dilatation balloon opens once. And as long as you cannot even expand the balloon with 50 atmospheres, you will not be able to put in a stent. So the second stent will not expand, and it will even more narrow the lumen you gained by the placement of the first stent. So if this would have been acute recoil due to the calcification after the stent was once fully expanded, then I would have used the second stent for sure, but not in this situation where the stent did not open. To the
so it was really heavily calcified. What about rod ablation?
As an initial procedure could be discussed, but
in retrospect,
but then I wouldn't have used it because I would have been concerned about the shower of even small particles into the kidney. Because everything what you are sending away, every particles are going into the kidney, and I don't believe that this is a good idea, to be honest. So, well, the only option here definitely, if you would have gone to an interventional approach here, would have been to try to pre-treat with a cutting balloon, and if this would have responded, then the next step would have been to put in a stent, and I did exactly follow this strategy in the second artery. So let's just start for the last 5 minutes of this case. So welcome. Here we can now see that there was another subtotal occluded second renal artery, but again the entire aorta was calcified.
The only could be just to make a surgery to make a revascularization, but
so at that time I had a fellow from Costa Rica who was vascular surgeon and atherectomy.
Well, for venous to the part of the surgery, could be good to make just the branch that could have bypass to the artery.
So let's go to 14 atmospheres. This is now a cutting balloon. It's a coronary cutting balloon. It's a 3 millimeter cutting balloon to pre-treat this lesion response quite good, which was eccentrically calcified, and interestingly the balloon did open, but there was a minimal lumen gain, almost no response. So now we ordered the 3 millimeter cutting balloon, improvement of the lumen.
The reason for using this device is to improve the vessel compliance. Oops. So there is some friction.
The next step here was then, as a consequence that the cutting balloon did open, I was introducing a coronary drug-eluting balloon.
So the balloon is not.
It's a pretty small artery open, and I believe that it makes sense to use a drug-eluting.
So the maximum pressure you should apply is 8 atmospheres, but it's important to allow the balloon to cut
What
into
balloon
the
is it?
vessel wall layers and into the plaque. Yeah. Okay. We have still a residual.
What is on the balloon in your in this case? What drug?
Pardon me?
What drug was on the balloon? What was
No,
the
it was a cutting balloon for preparation, and this is now a drug-eluting stent. That's the science.
All right. Yeah.
Nose at the origin. We see also the impact of the.
So pre-treatment was with a 3 mm cutting balloon followed by a 4 mm regular balloon, and now that's again a 4 mm
cutting balloon.
drug-eluting stent. But despite that, the 4 mm balloon did open, there was a lot of resistance at the end.
It's a little bit surprising, considering that this is a coronary drug-eluting stent science with a pretty good profile. Regarding all the discussions of using distal protection devices, you can see the limitation of protection devices in such situations. So 10 atmospheres.
Yeah, while discussion about protection devices are not really useful in such a kind of patient. So, well, the
Now we
stent
can see that the balloon opens quite nicely, still having a small waist,
yeah.
and as a reaction of that, the patient is complaining pain.
So this was probably a little bit oversizing of the denture here, and we will now see the final angiogram. So this looks
that
much
looks
better than
pretty satisfying. I'm pretty sure that this leaves a lot of discussion points for the podium after the presentation, and I would like to thank you for your attention, and we'll see you later. Bye bye.
well, yeah. So probably this was exactly the case you would not treat nowadays according to the outcome of CORAL and Astral, but I can tell you this patient definitely did benefit. He had a drop of blood pressure, mean blood pressure was 145, 46 systolic over 24 hours compared to 165 before treatment, and even renal function slightly improved, so there was a slight increase in GFR. So
very interesting case. I mean, we are running out of time, we recognize time, but are there any burning questions from the audience to Thomas Zeller or to the panelists there? Interesting case, I mean, double balloon technique. Yeah. Identify yourself, please.
Markus Hammer from Austria. At which point of this intervention would it have feared perforation of the vessel?
Well, when the patient would have complained of any pain, that's the best sign you can rely on. If the patient is not telling you any sensation, then you know that you do not yet overstretch the arterial wall. Yeah? And in the smaller artery, the patient did complain some pain because probably the 4 mm balloon was half a millimeter too big. So this is then a clear signal to stop and do not further extend the intervention or increase or upsize the balloon or the pressure.
So, I think we can sum it up, and Thomas Schmitz has this interesting